Hello everyone. I hope my stream started on YouTube. So let's start in this session. We are going to read endocrine pharmacology. So let's start with diabetes mellitus therapy. All patients with diabetes mellitus should receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment differs based on the type of diabetes and glycemic control. Type 1 diabetes mellitus, insulin replacement. Type 2 diabetes mellitus, oral agents, metformin is first line. Non-insulin injectable, insulin replacement. Weight loss, particularly helpful in lowering blood glucose. Gestational diabetes mellitus, insulin replacement if nutrition therapy and exercise alone fail. Regular short acting insulin is preferred in diabetic ketoacidosis IV, hyperkalemia plus glucose, stress, hyperglycemia. Okay, let's see this picture. Let's start from metformin and pioglitazone. Increases insulin sensitivity in adipose tissue, skeletal muscle. In glucose, decreases glucose production in liver. In intestine, decreases glucose reabsorption. In SGLT2 inhibitors in kidney, decreases glucose reabsorption. In intestine, decreases glucose absorption, glucosidase inhibitor. Pancreas, GLP-1 analog, DPP-4 inhibitor, amylin analog, decreases glucagon release, pancreas C cells. Stomach, decreases gastric emptying. Stomach, sulfonylureas, magletides, GLP-1 analog, DPP-4 inhibitors. Increases insulin secretion in pancreas. Okay, drug mechanism and adverse effect. Let's start with it. Insulin preparation, rapid acting, no lag. Lispro, aspart, glucine, short acting, regular, intermediate acting, NPH, long acting. Detemir, glargine, very long acting. Degludec, bind insulin receptor, tyrosine kinase activity. Liver, increases glucose storage as glycogen. Muscle, increase glycogen protein synthesis. Fat, increases triglyceride storage. Cell membrane, increases potassium uptake. Adverse effect, hypoglycemia, lipodystrophy, hypersensitivity reaction, rare. Weight gain. Okay. What insulin preparations do is bind to the insulin receptor, tyrosine kinase activity. Liver, increases glucose storage as glycogen. Muscle, increases glycogen and protein synthesis. Fat, increases triglyceride storage. Cell membrane, increases potassium uptake. Adverse effect, hypoglycemia, lipodystrophy, hypersensitivity reaction, rare, and weight gain. Plasma insulin level versus hours. Lispro, aspart, glucine, short acting, rapid acting, and short acting is regular. Intermediate acting is NPH, long acting is Detemir, and glargine. Okay. Diabetes mellitus therapy continued. Drug mechanism adverse effect. Metformin, pioglitazone. Okay, let's start with this. Metformin. Metformin inhibits mitochondrial glycerol 3-phosphate dehydrogenase (MGPD), leads to inhibition of hepatic gluconeogenesis and action of glucagon, inhibits mitochondrial glycerol 3-phosphate dehydrogenase (MGPD), leads to inhibition of hepatic gluconeogenesis and action of glucagon. Okay. Increases glycolysis, peripheral glucose uptake, increases insulin sensitivity. Adverse effect: GI upset, lactic acidosis. Use with caution in renal insufficiency, vitamin B12 deficiency, weight loss. Often desired. Pioglitazone activates PPAR gamma, a nuclear receptor, increases insulin sensitivity and levels of adiponectin, leads to regulation of glucose metabolism and fatty acid storage. Adverse effect: weight gain, edema, heart failure, increased risk of fractures, delayed onset of action, several weeks. Increase insulin secretion. Sulfonylureas, first generation. Clopramide, tolbutamide. Sulfonylureas, second generation. Glipizide, glyburide. Meglitinides, nataglinide, ripaglinide. Closes potassium channel in pancreatic beta cells membrane, leads to cell depolarization, leads to insulin release via increased calcium influx. Okay. Disulfiram like reaction with first generation sulfonylureas only, rarely used. Hypoglycemia, increased risk in renal insufficiency, weight gain. Okay. Increased glucose induced insulin secretion, GLP-1 analog, exenatide, liraglutide, semaglutide, decreases glucose release, decreases gastric emptying, increases glucose dependent insulin release. Adverse effect: nausea, vomiting, pancreatitis, weight loss, often desired, increases satiety, often desired. Okay. DPP-4 inhibitor inhibit DPP-4 enzyme that deactivates GLP-1, ligagliptin, saxagliptin, sitagliptin, leads to decreased glucagon release, decreased gastric emptying, increased glucose dependent insulin release, respiratory and urinary infection, weight neutral, increased satiety, often desired. Decreased glucose absorption, sodium glucose co-transporter inhibitor, canagliflozin, dapagliflozin, empagliflozin, blocks absorption of glucose in proximal convoluted tubule (PCT), glycosuria, UTI, vulvovaginal candidiasis, dehydration, orthostatic hypotension, weight loss, glucose flows in urine, use with caution in renal insufficiency, decreased efficacy with decreased GFR. Alpha glucosidase inhibitor, acarbose miglidol, inhibits intestinal brush border alpha glucosidase, leads to delayed carbohydrate hydrolysis and glucose absorption, leads to postprandial hyperglycemia. Okay, adverse effect GI upset, bloating, not recommended in adrenal insufficiency. Okay. Others amylin analog pramlintide decreases glucagon release, decreases gastric emptying. Adverse effect is hypoglycemia, nausea, increased satiety often desired. Okay, right now I'm just reading all of this, not giving time it to connect all these points and think out logically how I am connecting to build conceptual understanding of this. Yes, I have to do it. Yeah, sometimes these kinds of sessions will also happen. I am doing these sessions every day. Okay. Just by reading we are understanding and I am able to connect this point, just not thinking out loud because I have other things also do, but anyhow I have this 30 minutes and I have to read by giving full attention. I'm thinking if I don't correlate from conceptual understanding, I may save energy, and by reading fast I'm thinking if I okay, that's all useless. Just the point is I am not fully motivated to study at this time, but because of my discipline I am studying this. I want to study, but there are other things that are tempting right now other than the study. Okay, so how many minutes we have studied? For 13 minutes, 17 more minutes. So let's start with thionamides, profile thiouracil methimazole. Mechanism: block thyroid peroxidase, inhibiting the oxidation of iodide as well as organification and coupling of iodine. Leads to inhibition of thyroid hormone synthesis. PTU also blocks 5-deiodinase, decreases peripheral conversion of T4 to T3. Okay. Clinical use: hyperthyroidism. Procral thiouracil is used in primary first trimester of pregnancy due to methimazole teratogenicity. Methimazole is used in second and third trimester of pregnancy due to risk of PTU-induced hepatotoxicity. Not used to treat Graves' ophthalmopathy, treated with glucocorticoids. Okay. Adverse effects: skin rash, agranulocytosis, which is rare, aplastic anemia, hepatotoxicity. PTU use has been associated with ANCA, ANCA positive vasculitis. Methimazole is possible teratogen, can cause aplasia cutis. Levothyroxine mechanism: clinical use, adverse effect. Mechanism: hormone replacement for T4, levothyroxine. Levo is equal to 4 letters. T3 levothyroxine. Levo is equal to 3 letters. Avoid levothyroxine with antacid, bile acid resins or ferrous sulfate. Decreases absorption. Okay.
Clinical use hypothyroidism mixed edema may be misused for weight loss. Distinguish exogenous hyperthyroidism from endogenous hyperthyroidism using combination of TSH receptor antibodies, radioactive iodine uptake, and measurement of thyroid blood flow on ultrasound. Adverse effect: tachycardia, heat intolerance, tremors, arrhythmias. Okay. Hypothalamic pituitary drugs in clinical use: Conivaptan, tolvaptan, ADH antagonist, SIADH, block action of ADH at V2 receptor. Demeclocycline, ADH antagonist, tetracycline, SIADH interface with ADH signaling. Desmopressin, ADH analog. Central DI, von Willebrand disease, sleep enuresis, hemophilia A. Growth hormone, GH deficiency, Turner syndrome. Oxytocin, induction of labor, stimulates uterine contraction. Control uterine hemorrhage. Somatostatin, octreotide. Acromegaly, carcinoid syndrome, gastrinoma, glucagonoma. Esophageal varices. Okay, let's read it once again. Hypothalamic pituitary drugs and clinical use. It's good. It's few seconds. Drug and clinical use: Conivaptan, tolvaptan, ADH antagonist, SIADH, block action of ADH at V2 receptor. Demeclocycline, ADH antagonist, a tetracycline, SIADH interface with ADH signaling. Desmopressin, ADH analog, central DI, von Willebrand disease, sleep enuresis, hemophilia A. GH deficiency, Turner syndrome. Oxytocin, induction of labor, stimulates uterine contraction. Control uterine hemorrhage. Somatostatin, acromegaly, carcinoid syndrome, gastrinoma, glucagonoma, esophageal varices. Okay. Fludrocortisone, mechanism, clinical use, adverse effect. Mechanism: synthetic analog of aldosterone with glucocorticoid effect. Fludrocortisone retains fluid. Clinical use: mineralocorticoid replacement in primary adrenal insufficiency. Adverse effect similar to glucocorticoid, also edema, exacerbation of heart failure, hyperpigmentation. Cinacalcet, mechanism: sensitizes calcium sensing receptor CASR in parathyroid gland to circulating calcium, decreases PTH. Pronounced Cinacalcet. Clinical use: secondary hyperparathyroidism in patients with CKD, receiving hemodialysis, hypercalcemia in primary hyperparathyroidism if parathyroidectomy fails, or parathyroid carcinoma. Adverse effect: hypocalcemia. Sevelamer, mechanism: non-absorption phosphate binder that prevents phosphate absorption from the GI tract. Clinical use: hyperphosphatemia in CKD. Adverse effect: hypophosphatemia, GI upset. cation exchange resins, pateromer sodium polystyrene sulfonate, zirconium cyclosilicate. Mechanism binds potassium in colon in exchange for other cations such as sodium, calcium, leads to excreted potassium in feces. Clinical use hypercalcemia, adverse effect hypocalcemia, hypokalemia, and GI upset. Whoa! We have finished endocrine system from USMLE first aid. That's huge for us. We're reading daily consistently. Let's look at what we have read in these few sessions. We have completed total endocrine system. Okay, we started from last how many minutes? 8 minutes. Okay, in these 8 minutes we will see what topics we have read. We'll go through them, we'll look at them just to recollect what we have studied in this last sessions. Okay, and then we'll see in the last few minutes we'll see about the next session, that it will be most likely tomorrow morning, what we are going to read. Okay, we started endocrine system. Here they have given embryology. We started from embryology, then anatomy, physiology, pathology, and pharmacology. We have covered all this in an integrated way, right from endocrinology, anatomy, physiology, pathology, and pharmacology. The most challenging thing, we have to remember all the drugs in pharmacology. Pathophysiology we have embryology, how it develops, that will help us in anatomy. Then in pathology it will help more. Physiology will understand how normal physiology is going on, we understood that. Then how the pathology is occurring and how we can treat. So yeah, I like and one quote from this page, and which is very relatable to me and for all of us. Assume sometimes you need a little crisis to get your adrenal flowing and help you realize your potential. Yes, we need little crisis to happen, then only we'll start actually studying, learning, doing the work. If not, we'll just stay distracted and doing the useless things basically. Okay, they have given about the endocrine system. I have read this. Endocrine system comprises of widely distributed organs that work in highly integrated manner to orchestrate a state of hormonal equilibrium within the body. Generally speaking, endocrine diseases can be classified either as disease of underproduction or overproduction, or condition involving the development of mass lesion, which themselves may be associated with underproduction or overproduction of hormone. Therefore, the study of endocrine system, first by learning the glands, their hormones, their regulation, and then by integrating disease manifestation with diagnosis and management, take time to learn the multi-system connections. We have done exactly this. and I'm very happy with this. We read almost 28 pages. Okay, we started from embryology, thyroid development. We have seen the anatomy, pituitary gland, adrenal cortex and medulla, endocrine, pancreas, cell types. We have seen endocrine physiology. We have seen the hypothalamus, pituitary hormones, all the hormones we have studied, and anterior pituitary, posterior pituitary, hypothalamic pituitary, that connection. We have studied all the hormones, growth hormone, prolactin, thyroid hormone, parathyroid hormone, calcium homeostasis, calcitonin, glucagon, insulin, adrenal steroids and congenital adrenal hyperplasias. We have seen cortisol, appetite regulation, ghrelin, leptin, endocannabinoids, signaling pathways of endocrine hormones. We have seen how the pathways are for all the hormones, signaling pathways of steroid hormone. We have seen it. Then we started endocrine pathology. We have seen syndrome of inappropriate antidiuretic hormone secretion, primary polydipsia and diabetes insipidus, hypopituitarism, acromegaly, hypothyroidism versus hyperthyroidism. We have seen all the pictures, clinical notes. Hypothyroidism, Hashimoto's thyroiditis we have seen, and subacute granulomatous thyroiditis, Riedel thyroiditis, congenital hypothyroidism. For a second, I was reading that Hashimoto's disease. That's why I was silent for few seconds. Congenital hypothyroidism, other causes. We have seen hyperthyroidism, Graves' disease, toxic multinodular goiter, thyroid storm, Chord-Bestlow phenomena, causes of goiter, thyroid adenoma, thyroid cancer, papillary carcinoma, follicular carcinoma, medullary carcinoma, undifferentiated anaplastic carcinoma. We have seen diagnosing of parathyroid diseases. We have seen hyperparathyroidism, various lab values in hypocalcemic disorder. We have seen hyperparathyroid disorders, primary hyperparathyroidism, secondary and tertiary, familial hypocalciuric hypercalcemia. Then we started with the diabetes mellitus, type 1 versus type 2, hyperglycemic emergencies, hypoglycemia and IM, Cushing syndrome, Nelson syndrome, adrenal insufficiency, primary adrenal insufficiency, secondary and tertiary adrenal insufficiency, acute adrenal insufficiency, hyperaldosteronism, primary hyperaldosteronism, secondary hyperaldosteronism, neuroendocrine tumors, neuroblastoma, pheochromocytomas, multiple endocrine neoplasms, MEN1, MEN2A, MEN2B, pancreatic islet cells tumor, insuloma, gluconoma, somatostatinoma, carcinoid tumor, Zollinger-Ellison syndrome, endocrine pharmacology. We started today diabetes mellitus therapy. Diabetes mellitus therapy continued, that metformin, all the drugs we have seen, increasing insulin sensitivity, metformin and pioglitazone, increase insulin secretion, sulfonylureas, first gen chlorofluramide, butamide, sulfonylureas, second generation we have seen, glucose, increased glucose induced insulin secretion, GLP-1 analog, DPP-4 inhibitors, decreased glucose absorption, sodium glucose cotransporter 2 inhibitor, alpha glucosidase inhibitor, and other drugs we have seen. Also, thionamides, levothyroxine, levothyronine. We have seen hypothalamic pituitary drugs. We have seen, and the last fludrocortisone and cinacalcet, sevelamer, cation exchange resin. We have covered a lot, and we should be proud of it. Daily, consistently, we are reading. Oh, and it's already it's time to end our session. Perfect. From tomorrow, we'll start gastrointestinal system, and most probably tomorrow morning we'll try to read it before going my internship posting. I'm planning to read. Let's see how it goes. It's very challenging, but I'm going to try. If not, then later in the day, whenever we get time, we'll start it. And I want to do more sessions, but we'll see. Chalo fir. See you in the next session. We'll end now. Bye bye. Good night.